Meno. That is the Greek word for moon. And pause, as you can surmise, is pause to stop. In women who go through menopause, it's a very long pause. It's the duration of their lives. But the word menopause has really underserved women. Menopause just talks about the loss of the cycle, the loss of periods. And women have been taught to, love that, right? You don't have to have a period anymore. But the true meaning of menopause is great for women's lives, for women's health, and women's emotional health as well. Who thinks that if they exercise, they eat right, they meditate, they can avoid menopause? Anybody here? So you know how they say there are certain constants in life, like taxes and death? Well, for women, we should put in menopause. And I have a mission. This is sort of part 2 for those of you who may have joined me here last year. It's part 2 on promoting and educating on my favorite hormone, estrogen. And as many of you know, if I ask you a question, the answer is always estrogen. So you will always get 100 in my class. Those are my disclosures. So this is well known as well. Initially, when a new idea is presented, it is usually met with great disdain and often ridicule, right? But then after a while, it starts to become even worse. It becomes violently opposed. And then, if you wait long enough, and it is the truth, it becomes accepted to the point that everyone says, duh, everybody knows that. Well, where are we in the issue of estrogen? I think we have passed definitely through phase 1 and 2. I think we're actually getting to phase 3. Who here really thinks we may be approaching stage 3 for estrogen? I think it's day in the sun is about here. So menopause, it's natural. We agree that every woman who lives, if she lives long enough, as she should, will go through menopause. It's unavoidable. So it's natural. Why are we even talking about it, right? Why should we even worry about treating it? Well, everything that I consider aging is really about deficiencies. Think about this. Your heart muscle changes. It has new muscle. Do you think you have the same heart cells, the myocytes that you were born with? No, you don't, okay? Your heart muscle has a turnover of about every 4 years. Your bone about every 7 years. That's why they use, these drugs, Fosamax. I just want to mention as a side note, they say don't use it too long because it freezes bone turnover, and then you just get a bunch of dead, dense-looking bone, right? So that's why we don't want to do that. In heart muscle, you get a new heart muscle about every 4 years. When a new heart muscle is born, does it know how old you are? It doesn't know. It's born with the same genetic programming that the heart muscle that was created when you were 20 has. If we give it the information, if we give it the tools, it will behave the same. That's why if we do everything right, then we can have what we call health span. Live every day of our lives to the max, right? Until we hit true senescence. That's when we can't replicate our cells and replace the ones that die. That's why no matter how well you care for your dog, you're not going to have a 50-year-old dog. No matter how well you care for yourself, at this time, unless we can alter things, you're not going to be 150. It can't happen. But why can't we live all the way up until senescence sets in with health span? I believe we can, and that's certainly my goal for myself, and I do want to be a role for healthy female aging, and I want it for you and for all of your women patients, because these are the things that women will face after menopause. Dramatic acceleration of aging. Oh, have you ever seen a woman come in your office and she's on quite an array of pharmaceuticals? This is not atypical. I had a young woman in my office this week who was there for a totally unrelated purpose, but we were talking about menopause, and I was talking about what I'm dealing with and trying to help women with menopause, and I kind of went through the litany of all the different symptoms and problems that women face in menopause. And at the end, she said, "You just described my mom. My mom had all of those symptoms. She's on a whole slew of drugs. My mom is 62. This is not atypical. And I put in red the ones that kind of apply to brain function and mood. But actually, everything applies, right? Because everything is intermixed in the body, right? We know that we are one whole. So this just shows, again, some of the different things that women have to face as they go through menopause. And it's not something that any woman wants to face, right? Who wants all of these things happening to them? And if you ever saw your friend, we'll call her Mary. So Mary came, and she's like your old college chum, and you happen to see her at reunions when you and she were both 43, okay? Then you didn't see each other, and another decade went by, and Mary went through menopause when she was 47, which is not atypical. So now you're seeing Mary at age 53. The last time you saw her was 43. She looks really different. She's not on hormones. She's been eating the same. She's been exercising. And lo and behold, her whole body has morphed. Have you seen that? You have patients that say, I don't know why this is happening, because estrogen controls everything metabolic, including where fat gets deposited. And that's a very unpleasant thing for women. So here's, again, a lot of the symptoms that women deal with. And I put in red some of the ones that are, and I should have put in brain fog, that are sort of emotional and cognitive related. But as we know, everything is related. This is the shocker. Have you seen this in the medical literature? They say, oh my gosh, a new discovery. Women who have osteoporosis are more prone to having dementia. Why is that a shocker, right? It's all related to the same loss of estrogen, inflammation, right? We know osteoporosis is an inflammatory process. So is osteoarthritis. All of these things are interrelated. So what is this story with estrogen? I'm a gynecologist. I was trained in reproductive medicine, right? The menstrual cycle, having babies. I was taught estrogen is about reproduction. And that is true. But think of a car. Okay, so you go to buy a car, and the guy says, okay, you're going to buy this car, but I want to offer you something special. It's the special sporty package. And the sporty package consists of different grill work, different hubcaps, and you get a beautiful metallic finish. It doesn't affect the way the car runs, but it will look better, right? So you can get that if you want, but it won't matter. But it's $3,000. Okay, can you imagine if the guy at the sales office says, you know what, if you want, you could save some money, we'll just leave out the transmission. Like, maybe you don't want to do that. That's reproductive function in a woman. It's not the sporty package, it's the transmission, okay? You know that. I'm so happy when I see you know that, because it's all interrelated. What's the problem? All right, I'm going to give you a clue. The answer to this next question isn't estrogen. This is a trick. Okay, what's the prime directive of female life? Anyone know, what did we get evolved to do, females? It's not to run our own businesses, in case you were wondering. It's not to be great inventors. Sorry, it's to have babies. Every life form on Earth is evolved for reproduction. And in humans, reproductive success means that the mother has to live long enough to raise her child. You know, there are some creatures where as soon as they lay their eggs, somebody eats them, like the dad, you know, like some spiders, like, because you don't need them anymore. They're taking up valuable real estate. You know, who needs them? You know, I think, and I could have this wrong, but I think salmon swim upstream to spawn. They lay their eggs, and then that's the end of the road, because you don't need them anymore. Humans get to live longer, the females, because we have to raise our children. So everything in the female body is evolved for reproductive success and survival to raise the young. Okay? And there's a whole bunch of stuff we'll kind of touch on with that. So estrogen is the huge link. Estrogen is the master of metabolic homeostasis. Estrogen has a role in everything, not just reproduction. So when you lose estrogen with the onset of menopause, guess what you lose? Uh-oh. Oh, I get a lot of extra time because I forgot to turn on the timer. Does it work that way? Okay, so now I have no clue. So estrogen is about everything in female health. And I could spend all day talking about it, but I don't have that opportunity. But in the beginning, estrogen was present in creatures like mollusks, like clam-like creatures, who do not reproduce like humans, but they have estrogen. Why? Because it's about metabolic function. It's about creation of energy, use of energy for the survival of the creature. What is metabolism? It's like the life force. It's what keeps us alive. What's the difference between a living creature and a rock? A rock does not create its own energy. It can only reflect energy. We're alive as long as we can create energy. And utilizing and managing that energy is all under the auspices of estrogen. Estrogen has receptors everywhere in the body, everywhere. Notice on the immune cells. We talked about that a lot last year. I wanted to show you this so that you can see that estrogen comes from cholesterol. So I have to defend the defenseless, right? Like estrogen, sometimes fat, sometimes carbohydrates, and cholesterol. If you don't have cholesterol, how are you going to make any steroid hormone? You can see they all come from cholesterol. And all estrogen comes from androgens. All estradiol comes from testosterone. But the receptors for estrogen existed before the receptors for testosterone. Estrogen is the primordial hormone. And it's made in the ovaries from testosterone. So I wanted to show you that here we have our primary molecule from which all estrogens are created, all androgens, and progesterone. They all have a commonality. But look, mankind created pretend progesterones. And you know what they named them? Progestins. And if you look in the literature, even in scientific literature, they mix them up. Have you seen that? They use the word progesterone when they're talking about progestin, which is an endocrine disruptor for progesterone. And if any of you ever prescribe that stuff, you are going to hear from me, because that is bad news. And I talk about that, we'll talk more about in relationship to, for example, oral contraceptives, where they call that hormonal contraception. There's no hormones in any birth control pills, not a one. And I'd love to talk to you more about that, because women on birth control pills have higher rates of depression, and younger women higher rates of suicide, because they don't have real hormones. And of course, in menopause, that we're going to see, that of course applies as well in terms of mental health. So here's the three forms of estrogen, and they're different. They're not evil. They're just different. There's no evil estrogen. But they do different things, and you don't want to mix them up. And we're going to talk about why you always want to prescribe estradiol. That's the estrogen made primarily in the ovaries. That's the one that is, in essence, the reproductive estrogen. So estrogens have different effects on neurons, and estrone, which is made from aromatization, not from testosterone, but like from androstenedione in fat tissue, it actually reduces cell survival in the brain. And that's the dominant estrogen that's found in Premarin. And also, if you take an oral estrogen pill, it gets metabolized into estrone. So you can't talk about the health benefits of estradiol if you're giving estrone. So here's my analogy for that. You do a study on strawberry-flavored jelly beans. And at the end, the conclusion is, guess what? They give you higher rates of diabetes, obesity, and cavities. So never eat an organic strawberry. Okay, you figure that one out. Okay, but that's what they do in the scientific literature. It's crazy, right? What kind of conclusion can you make about A if you're testing B? But that's what we're dealing with. Whereas estradiol, as we'll see, is very neuroprotective. So during the menopausal transition, depression is a big deal. So here we have perimenopausal women are 4 times more likely to have depressive symptoms and 2.5 times more likely to be diagnosed with a major depressive disorder than before they became entering the menopausal transition. That's a big deal. And the solution in our country is to give them SSRIs. And we know from other data that estrogen is an anxiolytic. And one of the things I want to talk about, maybe next year if I get invited back, because this is a huge topic, is the relationship of estrogen and the endocannabinoid system. Okay, so here's a question. What hormone is essential for the endocannabinoid system to function properly? Okay, don't ever forget that. And estrogen is anxiolytic. And you know how it works? Through the endocannabinoid receptors, through increasing endogenous endocannabinoids. It's very, very important to know that there's a link there, because endocannabinoid system is kind of trendy now, but sometimes they forget that estrogen is key to its function. Maybe we can talk about that more next time. So here, if we look here at women going through menopause, if they've had a history of depression, oh my goodness, they're in the late perimenopause, 14 times greater chance of having depressive symptoms. And it's higher also by 3-fold in the early perimenopause. And it's linked to the amount of symptoms. Women with more symptoms are more likely to have depression. Well, that doesn't seem too shocking, but the regular conventional world doesn't get that. They don't get it, that there's a real correlation. And in fact, in this particular study, women who had 0 history of depression had a 50% increase in depressive symptoms, and 26% met the criteria for a true depressive disorder. Why does this matter to me? I'm going to tell you something I have never told anyone publicly. This is true. I'm telling you, this is from my heart. My paternal grandmother, I am named for her. She jumped out a window and died in the menopausal transition. My dad told me all about it. She was having the worst hot flashes that anyone could have. She had no history of any mental dysfunction, no depression. She couldn't sleep. Her symptoms were horrific. He used to put her in the car, the back seat of his car, open all the windows and drive as fast as he could to try to cool her down. This is true. And one night, something clicked. We don't know what. She just couldn't take it anymore. And she jumped out of a window and died. Suicide can happen. This matters to me. Your patients, even if they don't jump out a window, they are suffering needlessly. And the solution for a deficiency is to replete that deficiency. Okay? How do our brains get estrogen? Estrogen is so key to brain health, mood, everything. It makes estrogen in the brain. That's how men get estrogen. Men make 6 to 8 times as much estrogen in their brains as women do. And after menopause, women's brain continue to make estrogen. but not making up the difference from the loss of the ovarian production. That's why women have so much more depression, so many more problems with sleep, as we'll see. And they also have 3 times almost the amount of Alzheimer's disease. Estrogen comes from the circulation, from ovarian production. That's a huge part of how estrogen gets into the brain. And most of the problems that we face with children, and they're not getting proper brain development, is because of endocrine estrogen receptor problems from these chemicals. Lead is an estrogen endocrine disruptor. Mold is an estrogen endocrine disruptor. That's why they hurt the brain. Some of these are directly neurotoxic as well. So estrogen is directly neuroprotective. So you can see these on your slides. It increases brain-derived neurotrophic factor. It actually supports neuroplasticity and supports neurons themselves, and indirectly by improving glucose transport. Why do people with dementia do better on a keto diet or a high-fat diet? Because their transport system is broken. Because they have estrogen deficiency and inflammation. They can't transport estrogen, rather, they can't transport sugar into their brains. So you need another source of energy, because energy is life. And estrogen controls the production of nitric oxide and downregulates the inducible inflammatory nitric oxide. It maintains vascular health and the blood-brain barrier. It also maintains the circadian rhythm of melatonin, which is important in sleep. And women in menopause have tremendous sleep problems, even if you give them a little bit of estrogen and you reduce their hot flashes, because it's not enough to fix the underlying problems. And that's what we're going to talk about in a moment, is that if you treat with the conventional treatment, which is just to reduce hot flashes, it's not enough, because the amount of estradiol needed to reduce hot flashes is not enough to maintain all the other functions. So we have to look at that. So sleep is a huge problem for women, and we know that it affects, and we talked about this last year, the circadian clock. And so does testosterone. So just like a little plug for testosterone, testosterone also declines in women, not related to the menopause. By age 40, the average woman has half the testosterone level she had at age 20. Why is that? Because nature doesn't want women in their 40s reproducing. You know, testosterone has many functions, including it relates to libido. So serotonin neurons are actually neurons in the brain that make serotonin. They're supported by estrogen. And of course, we know that they do many, many important functions. And estrogen receptors, the beta receptor, there's alpha, beta, and membrane, and it's very complex. They are estrogen receptors on these neurons. And these neurons are supported in many, many different ways by estrogen in terms of the production of serotonin, the degradation, all kinds of ways, and supports the neuron itself. So serotonin is the precursor for melatonin, right? So, and this is not just in the brain, it's in the gut. I know you're learning about the gut. So this applies for the gut health too, and that's what we talked about. Gut health, brain health, bidirectional, very important for both. So now let's get down to some nitty-gritty here. What would be the optimal thing for a woman who goes through menopause? Now that we know that menopause is intrinsically bad for a woman's brain, it's bad for her health, it's bad for every aspect of her body. Nature designed reproduction to be linked to every other function. When you're not reproductive, every other function starts to go into decline. So what would be the ideal? Well, it would be to have an ovary transplant, right? An artificial ovary or an ovary pump or something for bioidentical. We don't have that. So everything we do after menopause is makeshift. We need to recognize we're concocting stuff. Now, if we take, now we're not going to do any oral, because I already told you oral estrogen gets metabolized into estrone, and estrone is not estradiol, and estradiol is the estrogen that does all these wonderful functions, especially in the brain. In fact, the conversion. You know, these things are bidirectional, that estradiol converts to estrone, and estrone can convert to estradiol. The enzymes for doing that do not exist in the brain. That's how much the brain loves estradiol and does not like estrone. Brain-produced estradiol does not convert into estrone. Okay, not in the brain. The brain doesn't want estrone. The estrone is bad. So if you take oral estradiol or Premarin, you're getting estrone. So we don't want to do our study with the strawberry-flavored jelly beans and get the wrong conclusion. So we don't want to use oral. So now we're using topical. Did we get evolved so our skin is like a delivery system for hormones? I don't think so. I don't think we evolved. No, nature never anticipated that we tried to give ourselves hormones through our skin. So we have to realize this is makeshift. We're concocting something. And when we put it on the skin, different people have different skin, right? Temperature, blood supply, amount of fat, thickness, different ages. So we're not going to get exactly the same. So we need to be recognizing that delivering hormones in the menopause is both science and art. And you have to be patient, and you have to tell your patients that we're just flying by the seat of our pants, you know? And there has been such a dearth of information after the Women's Health Initiative. We have not had adequate studies using bioidentical hormones. And as we'll see, the overwhelming trend was to give the smallest, you've heard this, the smallest dose for the shortest period of time because estrogen was viewed as harmful. Is that crazy or what? The hormone that supports every function in the female body is evil. It's just such insanity that, you know, have you ever felt like you lived in a parallel universe and you can't kind of figure out what's going on in that one because you don't even want to be part of that one? So the optimal would be to have real ovarian function. Given that we can't have that, what can we come up with? Well, we've already talked about what has been used conventionally, and most of the studies were involving these conjugated. What does it mean when they say conjugated equine estrogen? That's what CEE. Have you seen that expression? Conjugated. What does conjugated mean? It means that it went through the liver and went through the process called conjugation for the purpose of getting rid of it. So these are estrogens that have been altered by the pregnant horse to get rid of them. The horse doesn't even want them. I don't want them. The horse doesn't even want them. And they're not even one. They consist of like 17 different types of estrogen metabolites. And we know that estrogen metabolites have their own set of receptors. It's a whole different world. In fact, it's fascinating, the whole world of, and maybe we can talk about that another time, estrogen metabolites and the way they work in the body. There actually are receptors, for example, in the heart for 2-methoxyestradiol, which is a metabolite of estradiol, which actually helps to maintain heart function. Right? So it's like so what the heck are we doing with horse metabolites in us? So needless to say, this is not a good idea. And it's going through the GI tract, which alters it. And then synthetic progestins, we know they're rarely bad. And we're going to talk about that more. So this is just showing the structure of Premarin versus estradiol. They're different. I wanted to show you this because one of the things we're going to get to is hormones in a reproductive woman. Do you ever have the same amount produced by the ovary every day, a little bit every day, and a little bit of progesterone every day? Okay, we now know that when they came up with that idea, a little bit every day, the same, a little bit every day, progesterone, estrogen, nobody understood anything. Nobody understood there were estrogen receptors. No one even knew there was a circadian rhythm. Nobody knew much of anything. This is like prehistoric times, okay? Do we say to someone, eat a vegetable? It doesn't matter if you eat one vegetable, like one carrot. We'll say, eat one carrot a month. You get your carrot. You get your vegetable. That doesn't make sense. Eat one carrot a month? What if we said, we're going to give you a whiff of estradiol? What? You know, now we know it's not just what you eat. It's when you eat, and it's how much you eat. Right? If you eat the same meal at 3 o'clock in the morning versus 3 o'clock in the afternoon, it has a totally different effect on your body. If you take a teeny bit of estrogen, it has a very different effect. We're going to see Estradiol is dose-related. A little bit of estradiol is actually inflammatory, and a high level, physiologic high level, is anti-inflammatory. So what we have promoted is giving an inflammatory dose of estradiol. It's like crazy. So what is this? This is from the package insert of Evamist, which is a conventional estrogen delivery system through a spray. It's a spray on the skin thing. And it shows, what does it show? It shows that if you put it on in the morning, then you get your peak estrogen level in your blood 18 to 22 hours later. So between 2 a.m. and 6 a.m., you're going to have your peak estradiol level. Estradiol is circadian. We put out more in pulses, which are called ultradian, in the earlier part of the day. Okay? We do not peak our estrogen at 3 in the morning. Okay? So it's not just what you give, it's when you give it. So we're not giving anything in accordance with nature. I'm very simple-minded. I just say nature knows better than me. I am not going to outsmart nature. So my goal when I care for patients is to do what I can to mimic nature. I want to give real food. I want to give real hormones. And I want to give everything in the rhythms. Did you know that we have a beautiful dance, we women, when we're reproductive with the moon? We dance with the moon. We have a rhythm with the moon. We're not doing that when we're standard replacing hormones. And progesterone, we looked at the difference between real progesterone and progestin. So these I want to go over with you. This is real world. These are the commercial products. This is probably what you're going to use with your patients, at least in the beginning. But this is Hormones 101, and I'm also going to go into Hormones Advanced course for those of you who feel that you're ready, at least to hear it. Many of you may never prescribe hormones, but I want you to know about it, and I want you to be able to evaluate your own patients who are on it or not on it, and hopefully encourage them to go on it and not to be afraid of it. Is it natural to go on hormones in the menopause? No. But how come we don't have a problem with joint replacement, cataract surgery, pharmaceuticals, stents, defibrillators implanted? I mean, we don't seem to have a problem with anything that's artificial except giving estrogen. Okay, so, and we're going to give bioidentical estrogen. So the estrogen patches. Here are the different strengths. Now, we're going to go more into it. I already told you that low levels of estrogen are inflammatory, and higher levels are anti-inflammatory. So do you think that you would want to pick this dose or this dose? Well, this dose. Okay? This is the only dose of estrogen patches that have been shown to actually help conserve bone. That's a good clue, right? Really, and even build a little bone. So you want to have the highest physiological level in terms of measuring levels. If a woman is not on any hormones, for sure you want to go with serum. And I still use serum, but I'm working with some labs now, and next year I can update you on what I've learned about using other types of modalities besides just serum. But that's what I've been using. And so for serum levels, you would want to have a minimum of 50 micrograms per picograms per milliliter, okay? 50. They've shown that anything under 50 will not maintain the vaginal health at all. And many times you have to get up to around 100. And sometimes it's hard to get up to those levels, but at least you can use the highest dose and see where you're at if you're using the conventional. There's estrogel. That's a gel for the arm. That's the dose. So many women, if you use one pump, it's inadequate. In Europe, they typically use 2 pumps, 1 pump for each arm. It's an alcohol base, so you just wipe it on the arm in the morning, let it air dry. Okay? So these are static doses, but this is the conventional. I'm not going to tell you that you should breach convention because, you know, I don't want to get you in trouble with your medical boards, but I'm going to tell you what's real and what's not real, okay, in terms of real science. But this is conventional. Do I think that any estrogen is better than no estrogen? Yes. Even 1 carrot a month is better than no carrots a month, okay? So we have to deal with reality, and it's going to change, but not so soon, I'm afraid. It may take another decade or more. But so the patches are easy to use. You put it on the abdomen, and you change it twice a week, every 3.5 days. Try to go with a higher dose, not a lower dose. And I'm giving you a lot of information so you can educate your patients, because I'll bet you dollars to donuts, they're afraid. They're afraid of estrogen. They have been so brainwashed. You're going to have to gently teach them and give them time to absorb this information. There's Divigel, which is for the thigh. It comes in these doses. I try to use this one. This one, when you look at their tests, when you look at their studies, their levels in the serum are sometimes like 15. 15? I see postmenopausal women with better levels. It's so crazy. Why am I giving something that's expensive and it's actually a placebo? You know, it's crazy. And then there's the Evamist I mentioned, the spray. I don't actually use that. And then there's the Femring, which is a ring that sits in the vagina, and it delivers, it's actually a precursor to estradiol, but it gets converted to estradiol, and it comes in these 2 strengths. And it sits in for 90 days. It can sit in the vagina. It could be removed and replaced and put back in. And then there's the pill, which we do not want to use because it turns into estrone. And then there's the progesterone pill, which gets metabolized, but it has a lot of data on it. These are 2 sort of made-up amounts. You know, everything's kind of made up, right? Made up. But we know that this will keep you out of trouble and generally protects from endometrial hyperplasia, which will happen in a certain percentage of women if you have unopposed estrogen, because estrogen is about growth, healing, and proliferation. If you get a cut and you don't have any estrogen, you're not going to heal. The skin actually makes estrogen. So estrogen activates the platelet. Estrogen maintains the platelet health. Estrogen controls like VEGF, you know, vascular endothelial growth factor. All these things are controlled by estrogen, the growth factors, the enzymes controlling these things. And estrogen is about growth and proliferation, but in a controlled fashion. Okay, so we definitely want to have progesterone as well, not just estrogen, even if you don't have a uterus, because progesterone also it's like, I call it estrogen's sidekick, you know? Batman without Robin isn't doing well. Estrogen without progesterone, even though it's a lower level, it's still super important. So you need progesterone, and progesterone did not get created in a woman to prevent endometrial hyperplasia. It has way more effects than that. So progesterone is in itself neuroprotective, right? So you know that. So progesterone is wonderful. We want that as well. So progesterone, when it's given, they often give it nightly, every night, because in a lot of women it will keep them from bleeding. And women have been trained, and I get it, you know, I am a woman, that bleeding is annoying. Having a period is annoying, but it is what we are. You know, we are, you know, sometimes we don't want to do something. Maybe we don't want to ever exercise because we love sitting on a couch. But that doesn't make it right that we just sit on a couch. Our bodies were designed in a certain way. Why don't we just come to terms with it, okay? Women are designed to be rhythmic and lunar, and there's a lot of data, which I'll show you some, that shows that if you give the progesterone for 14 days a month, even in a static estrogen environment where you're giving the same dose of estrogen every day, it helps reduce breast cancer. That's enough for me. And if they bleed, say, put up with it and celebrate your femininity, right? Because it's part of what we're designed to be. And testosterone is also very important, and you can't get it in this country except through a compounded pharmacy. And women have far less testosterone than men, about 1/10 the amount. So you don't want to go too high. But if you start even low, you can work your way up and see how it goes, like 1 to 4 grams once or twice a day. It's hard to get people to do things twice a day, but it's better because our ovaries and our adrenals, which makes half the testosterone, they don't just put out a bolus once a day. That isn't how it works. but it's pulse. Look at the great advances they did with diabetics, having an insulin pump, because you don't want to just do like a giant one dose, right? So, but we don't have that. So the optimal would be for like estrogen if you used a cream and you put on different amounts all day long, but who's going to do that, right? But that would be more mimicking an ovary, because the ovary puts out pulses. That's what we call ultradian rhythm. So why do we not use Biest? Okay, this comes up all the time. Estriol is the hormone that's dominant in pregnancy for a good reason. Everything in life is for a good reason. So estriol is the hormone that works only on beta receptors. Pregnancy is a time when you're harboring an alien creature. This is alien genetics, it's alien tissue, so our bodies could reject it. Women have very robust immune system, much more so than men. And women's immune system would just kill it. Would just kill that little fetus in there. So we have to dismantle, to a great deal, our innate immune system when you're pregnant. And the immune cells of the innate part, like mast cells, macrophages, neutrophils, they all have estrogen receptor alpha. Alpha. What else has a lot of alpha? Oh, how about the hippocampus? You want any memory? How about the hypothalamus? You want to control your appetite and a lot of your metabolic functions. Those are all alpha. And beta is, and it's all just dominant. Beta tends to be more in the cortex, the endothelium of arteries, the gut lining, and the T and B cells, okay, the T and B cells. So, but when you have high amounts of beta receptor, it downregulates alpha. So by putting out all this beta, you're actually downregulating alpha. You're essentially on like an immune modulator, like Remicade or Humira. You're getting rid of your ability to make things like the interleukin-6s, and you're getting rid of the tumor necrosis factor alpha. You're downregulating your innate immune system. And you probably know that pregnant women are more likely to die if they get the flu or they get chickenpox. Why is that? Because their innate immune system is downregulated, and they tend to have remissions of their autoimmune disease. They tend to do better. Why is that? Because they're on like a natural immune modulator. But do you want to do this to your women who are in menopause? Women have a great advantage at fighting infections. If you have an epidemic or you get septic and you're a female, you have a substantially higher chance of surviving than a male. And why did nature do that? Because you have only so much energy in your body. You only have so much to expend. And you have to decide where you're going to evolve to spend it. So women have to survive to raise the children and to have more children. Men, we love you, but we could have 1 man to 10 females. We could get by, right? Men like that, yeah, but you got to get rid of all those other men, right? Because you got to compete, right? So nature made it so that women have this incredibly robust immune system so we can survive a lot of sepsis and plagues and infections. And men, they have energy. Where are they putting it? Into brawn, big muscles and bone and higher stature, and making all those sperm. That takes a lot of energy, you guys. So that's where your energy is going, not into your immune system. So do you want to take an immune system of a woman and dismantle it? And are you going to give her the fine print at the bottom of your estrogen? You may die of an infection, kind of like the same thing on Remicade and Humira. It's like, oh, you might die of an infection or you might get cancer. You might get leukemia, lymphoma. That's what you're putting your patients at risk for when you give them a lot of estriol. Why would you do that? Don't do that. Now, if you're treating breast cancer, how did that come about? Because I just told you that a lot of beta downregulates alpha. Well, it turns out in the breast, there's a lot of alpha. And as we're going to go over, breast cancer changes everything. Estrogen works differently in a breast cancer environment. So if you're treating something, like say you're treating multiple sclerosis, and you're trying to create a pregnancy-like state where you're down-regulating. You're sort of creating a natural immune modulator, okay? If you're treating a certain disease state, maybe it makes sense to give estriol. But I'm not talking about that. I'm talking about hormone therapy in the typical menopausal woman. You don't want to down-regulate her alpha receptors, okay? Now, remember, the vagina is mostly beta receptor. So why is that? Because how the heck does a baby get out of vagina? It's like a snake swallowing that pig. You know, like, how does this do it? How does it stretch like that? If you somehow put a baby in a woman who wasn't pregnant by, you know, some spell, and you said, okay, now push this baby out, she would just rip up. Okay, she is special. A woman has a totally different stretchy vagina. That's why estriol can be used for vaginal health in the menopause. That's a special use, okay? It has all those beta receptors. So, are you going to use Biest? The answer is no. That wasn't estrogen. That was another trick question. That was a yes-no. So please don't use Biest. So we know that we use a lot of static, but now what I want you to do is try to go and get your women patients to use estrogen only 14 days a month with the higher dose of the progesterone, please. And please try to go with the highest dose that you can get your patient to take of the commercial products. Maybe you want to do a little break here and there. This is theoretical, because long-term continued exposure at a static level is going to downregulate your receptors. That's why many women will start having symptoms again later. That's why static dosing is really stupid dosing, but that's the conventional right now. But sometimes we have to do something that's better. It's not best. We just have to live in the real world to some degree. And then wait until you get your estrogen and progesterone right, and then add the testosterone, because testosterone is primed, the receptor's primed by the estrogen. Get the estrogen right, and then add the testosterone. And not the other way. Don't just give testosterone. It won't work properly. Okay, you need estrogen to prime the receptor, as we'll see. So make sure your patients get exams. If you don't do female exams and pelvics and breast checks, make sure somebody does, okay? You want to get sued? I recommend getting a mammogram first. I'm not a huge mammogram fan, because I know you have to do like 1,000 to prevent one death, but you want to protect yourself. Plus, and I will show this, if you have a patient with very dense breasts, that means they have inherently inflamed breasts. And inflammation leads to DNA breakage. That woman has a higher risk for breast cancer. You probably heard that. Density on a mammogram is a risk factor independent of any other factor for breast cancer. It's because it means the breasts are inflamed. And you don't want to just say, oh, you have a higher risk. You've got to deal with that inflammation, right? Their diet, their sleep, there's chemicals, their toxic load. There's something wrong. Don't just say, oh, you have a higher risk and have a nice day. That's not doing your... And if they have a higher risk for breast cancer, do they have a higher risk for dementia and depression? Yes, because we know that inflammation doesn't just reside in one spot, right? So they probably have neuroinflammation too. So we want to make sure that if they have a lot of breast tenderness in the beginning, what do you want to do? You actually want to give them more estrogen, because estrogen upregulates the progesterone receptors, and give them a little bit less progesterone for a little while. It sometimes takes a while for those progesterone receptors to mature, to work properly, and then the breast tenderness will go down. That's why, like, women in early pregnancy will have so much breast tenderness. They don't even have the highest levels because they're making a lot of progesterone, and the progesterone receptors are not yet mature, but it will get better over time. Help them sleep by giving them melatonin, because remember, they need to have serotonin neurons working properly. That will take time. Serotonin neurons will degenerate and wither away as time goes by. Early is better than late start. The earlier in the transition that women get started on hormones, the better. So we're going to look at lots of history taking. You have this, so you don't need me to read this to you. You want to know your patient. Do you know that a woman who breastfeeds has lower risk of breast cancer, right? We know that nursing is very beneficial to women. It actually does some epigenetic modification of the breast. And the earlier you have babies, the better. If every woman had a baby before she was 20 and then nursed for 3 years, her risk of breast cancer would plummet. But go get people to do that. Who in this room, either themselves or someone in their family, has had a baby before age 20 and then nursed for 3 years? Whoa, I am impressed that there's anyone. But I was kind of not looking to have a baby at that time. So most of us, are going against our genetic, destiny. And so I want to mention, I'm going to talk now about the advanced hormones, when you give it to take into account that chronic low estrogen, or none, if you don't have any coming from your ovaries. You always have estrogen, right? Because organs make estrogen. That's why we don't die. That's why drugs like Femara and Arimidex, these aromatase inhibitors, are so horrible for women, because then they don't make estrogen in the organs. That's called paracrine. The endocrine is when hormone is made, it travels through the blood to a distant site. Paracrine is when the hormone is made in that organ for its own use. Intracrine is when it's made in the cell for its own use in that cell. So men get all their estrogen through paracrine. They make it on site in their own organs. Many, many organs make estrogen. But when you're on a drug like Arimidex or Femara, it does terrible things to the brain, terrible things, because they can't make estrogen anywhere. It's so terrible for them. And you lose genomic control. Do more women have cancer before or after menopause? After. And when they have it before, and it's like, it's typically because they were exposed to so many toxins, right? The toxins are causing all these cancers. So here's the beautiful rhythm of a woman, the dance of the hormones. And it's very different when you give hormones static or rhythmic. Rhythmic is really physiologic. Remember, if we had the optimal situation, we would give everyone back their ovarian function. A woman is healthiest when she's like 25 and has real hormones in her body, not when she's 65 and has none coming from her ovaries. Just think. Like, which would you rather be, 25 or 65 when it comes to health, right? And it's related a lot to ovarian function. So this is the standard. Do nothing when women go through menopause. Give pharmaceuticals of all sorts. Give some static hormones. Or maybe the future is going to be rhythmic restoration to try. Right now, like I said, we're like in the Stone Age at doing it. But that's where we need to do research. And I'm actually working with a nonprofit to raise money to do research with rhythmic hormones in Mexico, because it's a heck of a lot cheaper there. So this is where we're at. So this is actually looking at birth control pills, but does this kind of picture look like this kind of picture? No, we need our dance. So when we use hormones, okay, we want to use hormones that look and act and are chemically just like human hormones. That's pretty clear. Do we want to eat food that contains plastic like we do? No, we don't really want to eat plastic food. We don't want to eat chemical food. We want to eat real food. And we want to have real hormones, and we want to have it to mimic, in an optimal world, to mimic the way our ovaries do. Now let's see what that means to the body. So when you have this spike of estrogen on day 12 in a 28-day cycle, what happens when that estrogen spikes up? It opens up or upregulates the receptors for thyroid, progesterone, testosterone. Do you know many women have depression in menopause because their thyroid isn't working right? Have you ever seen women, they have all the symptoms of hypothyroidism, but you measure the levels, they say they're normal, and then the doctor says, another crazy woman, here's some Prozac, because you're just crazy. But it doesn't matter how much hormone we have, and we know this with insulin. How come we can't remember that other hormones have receptors, right? So insulin, you can have plenty of insulin, but if it doesn't work with the receptor, you're not getting the sugar into the cell. And then the cell is starving, and you have all this inflammatory state, and you're building fat like crazy, right? So if you have thyroid receptors that are like this. Okay, so we know they always talk about receptor is like this. You have ever seen a receptor? It looks like this, and then here comes the hormone. That's not the way the receptor is. Does everyone know Jim Carrey, the actor? He's kind of a little old-fashioned. But remember his mouth? He could do like weird things with his mouth. That's like a receptor. They're not static. They're like Jim Carrey's mouth. They open, they close, they do weird things. And oh my gosh, the thyroid can't function. It can't get in. It's like, open up. Okay, here's another thing. You go out, you have a baby, okay? You have this beautiful baby, and you read this article in Woman's Day magazine. It said, mashed peas are good for babies. So you go out and you buy all these fresh peas, and you put it in your Vitamix, and you make all this pureed pea, all this peas. Okay, so you get it ready, and you get the spoon, and you go to the baby's mouth, and the baby sniffs it and says, I don't think I like mashed peas. So the baby goes like this with the mouth. So here you have tons of mashed peas. Does it matter? It's not getting in the receptor. It's not doing any good. Doesn't matter how much thyroid hormone if it doesn't work. Same with thyroid, same with progesterone. The receptors need to be receptive. The spike of estrogen sets the tone for those receptors. We're not getting that with the static. And then when you get this spike, it's not really a spike, we'll call it the peak of progesterone in the mid-luteal phase, you know, the beautiful dance of progesterone, it goes up and down. That high level of progesterone upregulates P53, the tumor suppressor gene. Nature did not make it so our menstrual cycles give us breast cancer. Our bodies are designed to prevent cancer when everything is right, but you need the rhythm. But at least when you give progesterone pulsed 14 days a month, it does some good. It does some good. Best, no. Better, yes. So here, when estrogen dominance, can we please throw out that term? Because usually it means progesterone deficiency, okay? And thank you. And the deficiency of the peak of progesterone means that you're going to have deactivation, and you're not going to have, when you don't have that spike, when you don't have these things happening, you're not going to have what? When you don't have the estrogen peak, you're not going to have testosterone receptors activated. You're going to have reduced libido. Have you ever heard of women in menopause saying, I don't have much sex drive? Like, duh, they all do. Because you need to have that spike of estrogen. Why did nature do that? Because that's when you're ovulating. It's all about conception, right? So nature wants women to have a sex drive when they're fertile, when they're ovulating. Duh, okay? Remember, now you know, now we're into the third phase, the duh phase. Everything seems obvious, right? And progesterone, without that, you don't activate your tumor suppressor gene. You actually reduce your chance of having healthy bone, and you downregulate your estrogen receptors in bad ways. So we need to have these rhythms, the beautiful rhythm of women. And once again, I mentioned that if you have static dosing over time, the receptors become resistant. And I know there's a lot of people pushing pellets. Do you think I like pellets? No, I do not like pellets. They are not physiological. Remember I said I'm simple-minded. Nature knows best. I'm just trying to mimic nature. I cannot outdo nature. Pellets are not mimicking nature. Please do not do pellets. Progesterone we talked about. I don't care that you don't want a period. You're a female. Get over it. This is the risk that this is what you're facing, guys, and you have it. These are the risks. You're going to have to deal with this with your patients because they're going to read this, and they're going to come back to you, and they're going to say, excuse me, are you trying to kill me? You know, like, did you read the insert? Do you know anything, right? Have you had that? Like, do you know what you're giving me, that you're trying to kill me? So you need to know how to deal with these issues, right? You need to say, but that's not what I'm giving you, but that's not what I'm giving you, but that's not what I'm giving you. These studies were with something else. They were studies on strawberry-flavored jelly beans. I'm giving you the organic strawberry. And this is all the stuff that you can look at later on the Women's Health Initiative. You know, even using Prem-Pro, medroxyprogesterone acetate, and conjugated equine estrogen, you still only had a very small increase in breast cancer. And where did it come from? It came from this part, not from this part. As we'll see, there's a slide in there that shows that women on just this, equine estrogen, had actually a lower incidence of breast cancer, which I'm going to explain to you. So here's all the data that you can see. I just wanted you to see that in the women in the 50s, they had substantially lower all-cause mortality, lower. So is there any drug that lowers your risk of dying in your 50s by at least a third? No. But even using stupid Prempro, they had a reduction of that magnitude, and nobody even talks about it. So overall, we know that there are many, many observational studies that show dramatic reduction in coronary heart disease, very significant published studies. And this Danish study showed that cycling of hormones was better than static for reducing heart attacks. Now, I have to touch on breast cancer because that comes up all the time. If you're going to give hormones, this is going to come up. So there just is what it is. It shows that if you give it in a combined rhythm where you're doing sequential rather than giving it continuous, you have lower risk for breast cancer. So I want you to be able to tell your patients that there is data on that. And okay, so what happens? I'm going to give you, in a nutshell, why women get breast cancer and what happens with estrogen in it. You have inflammation in your breast. I told you that. Then it shows on breast density is increased on a mammogram. You have inflammation. Menopause is inherently an inflammatory state. You have gut dysbiosis. You have alteration in the regulation of your immune cells. You have insulin resistance. You have fat problems. You know, your adipose tissues, your adipokines change. You have lower levels of adiponectin. You have metabolic dysfunction. You are inflamed when you're in menopause. And the inflammation goes everywhere, including in the breast. Inflammation with unrestricted proliferation can lead to DNA breakage. Estrogen, I told you, is about healing. It's about love and nurturing. It's trying to fix a cut. It's trying to help you. We did not evolve with cancer. You know, cancer is a new disease. Ancient civilizations, they had their own problems, but they didn't die of cancer. So we did not evolve to fight established cancer. We can kill off incipient cancer cells. And we do that a lot with exercise and fasting regimens and all the things that we evolved with. But once you have established cancer, our bodies were not evolved to deal with that. So estrogen doesn't get it. Have you ever seen that movie? It's kind of old with Sissy Spacek, Rosemary's Baby. Okay, so here's this woman, if you don't know. So here's this lovely young woman, and she gets impregnated by the devil. And she gets pregnant. And she has a baby. It's Rosemary's baby, but it's the devil. But she doesn't know it. It's her baby. So she's nurturing and loving her baby. Estrogen doesn't know that that's cancer. It just thinks it's sick. It's not healthy cells, so it's trying to nurture it. So everything, all the genetics are altered so that estrogen is trying to heal it. How does estrogen heal? It creates new blood vessels. It creates new proliferation. So estrogen, once you have cancer, like breast cancer, everything is different. Estrogen does not cause cancer, but it might act as a promoter of small existing cancers because it's trying to heal them, and in the process of healing them, it's promoting them. But let's not blame Rosemary for getting that baby. It's not her fault. She didn't know it was the devil that got her pregnant. So here we have this stuff that you can read, because I don't want to read that to you. But even with the equine estrogen, it reduced breast cancer by 23%. How is that? Because if you don't have cancer before you get breast cancer, estrogen is anti-inflammatory when you have a lot of it. Estrogen is anti-inflammatory. It's really important to know it's dose-related. A little bit is inflammatory, a lot is anti-inflammatory. When is the estrogen the highest in the menstrual cycle? At the spike preceding ovulation. Why is that? Because you want to downregulate your immune system so you don't kill the sperm, because they're aliens too. So you want to downregulate, you want to quiet down your immune system with higher levels, okay? So estrogen is breast cancer protective. It's totally different before you get it. And in fact, here's all the data that you can look at. This is a tumor suppressor gene. When you have high amounts of serum estrogen, it actually promotes this gene, which does what? It's a tumor suppressor. It inhibits cell growth, migration, and invasion. You need to have higher levels of estrogen for this to come into play. And here it shows, here's that gene, and see it blocks. Do you ever hear this? Phosphatidylinositol 3 kinase. This is a growth promoter, like insulin growth factor 1, IGF-1, endothelial growth factor, insulin. These are growth promoters. Now, it's not that we don't want to have them. We just don't want to have them all the time, because that's unremitting proliferation and growth stimulation. But estrogen shuts this down so you can have reduced cell division and you can have appropriate death of sick cells. So here's another one. Inflammation promotes aromatase. Why is that? Because aromatase produces estrogen. Estrogen is designed to modulate inflammation and reduce it. So you've heard of prostaglandins. Prostaglandin E2 is produced in an atmosphere of inflammation, okay? And estrogen reduces the production through activating a gene and lowers the amount of the inflammatory prostaglandin E2, and prostaglandin E2 promotes the induction of aromatase. Because if you don't have inflammation, you don't need to produce more estrogen. So inflammation causes more estrogen production. So this is a clue. When you have dense breasts, the body is trying to reduce the inflammation by making more estrogen. It's upregulating aromatase. If you can lower that woman's inflammation, her breasts will be less dense. And then when you have less inflammation and less proliferation, you'll have less DNA breakage and less breast cancer. You're giving women hormones in menopause can lower their risk of breast cancer. It's like everything is flipped on its head. Everything that was being told was wrong. That's why I've been living in a parallel universe. It's so crazy. And this just shows you, and this applies to men, you guys. Why do men get boobs? Why do they get enlarged prostates? The prostate is the analogous organ to the uterus. It means they are inflamed. A man with a large prostate, the solution isn't just, give him, Flonase and do a Urolift and pull his prostate apart from his urethra so he can void. That's not the ultimate solution. Get that inflammation down in that guy. And by the way, he probably needs more testosterone, right? Because testosterone is converted into estrogen as well as having its own receptors. So we definitely want, and then here's another. When you have higher levels of serum estrogen, you upregulate this particular gene that causes cells to stay cohesive so that you won't have cells breaking off like metastases, right? So you have cohesion of cells. You don't have breakage and things falling apart when you have estrogen. So when you have a breast cancer, everything changes. But what's interesting is that the way the genes are expressed in the breast in breast cancers is very similar to that in breast tissue before it becomes cancer in women with low estrogen levels. Because the way genes are expressed, it's about how much estrogen. But remember, it's also about the rhythm. And the rhythm will come. As we spread the word, we'll get more data on the rhythms. But don't let the fact that what we're doing with static, that it's not best, don't let it keep you from doing it, okay? Because they still need it. Just try to give it in the highest amounts. So everything is the opposite when you have breast cancer. It turns everything upside down on its head in breast cancer in the way the genes are expressed. And P53, the guardian of the genome, I mentioned that it's upregulated when you have that elevation of progesterone, and it tells cells to either repair or kill themselves. Either get your act together or die. That's what P53 says to those cells. Estrogen and blood clotting. High levels of estrogen in the physiologic range are anti-blood clotting. Remember, they promote health. Estrogen controls an enzyme called prostacyclin and also COX-1, and those reduce blood clotting. That's why if you give a drug like ibuprofen you increase the risk of someone getting a heart attack or a stroke because you're blocking COX-1, which is about anti-clotting, but you're also blocking some COX-2, which is an inducible enzyme, which goes into play when you're injured, like you get attacked by a wild boar and you're cut and you've got to clot so you don't bleed to death. But you're blocking both. And prostacyclin is an enzyme that's controlled by estrogen, which lowers platelet aggregation. Estrogen reduces that. But the thing is that in pregnancy is actually something of an inflammatory state, and you're down-regulating some of the platelets on purpose because a woman is going to have a baby. She will bleed to death. Everything is for a purpose. A woman who is pregnant is more hypercoagulable so she doesn't die from hemorrhage when the placenta separates. I'm an obstetrician. Who else has ever seen a woman hemorrhage after a delivery? Oh my God, you say, please start clotting, right? That's what nature, so everything is for a purpose. But in women who are not pregnant, they do not have hypercoagulability. Who's more likely to get a PE, a young person or an old person? An old person who doesn't have estrogen. And birth control pills have no estrogen, remember that. And they dysregulate your platelet function. Estrogen is great for preventing blood clots. Everything is turned upside down. And here we have studies that show exactly that. It does not, in high levels, normal endogenous levels, high levels of estradiol and testosterone in women and in men are not associated with increased risk of blood clots. I have to give you this information because if you're going to start promoting hormone use, you've got to fight every battle here because they're going to say, look at the insert. It gives me this and this and this. That's why I included that stuff. And you're trying to kill me. You have to tell them I'm not really trying to kill you. I'm trying to help you because everything you've heard is wrong. So estrogen can do so much along with its cohorts, progesterone, testosterone, to make life so much better. Do not be afraid of estrogen. Okay, what is the master of metabolic hormone homeostasis? What is the giver of life, the reaper of everything good in a woman? What is that hormone? Estrogen. Do you love it? Do you feel the love? Okay. Thank you so much.